All right. Welcome to the Auditory Learner. This video um, is going to be for pharmacology. This is going to be the second video for pharmacology study guide for the first midterm. In this video, we are going to be covering chapters 2.1, 2.2, 2.3, and 3.1. Okay. And so just to review again, these are going to be how drugs work, which includes cell signaling and enzymes, the mechanisms, the routes of administration, the pharmacokinetics, and the efficacy and adverse reactions. All right. So let's begin with chapter 2.1 on how drugs work, cell signaling and enzymes. Okay, so from the lecture quiz Q&A, we found out that isopropernol is a ligand. We found out that hydrophilic or ionized molecules do not pass the cell membrane. We also found that hydrophobic drugs do pass the cell membranes, and hydrophobic drugs are like sex hormones. So they do pass the cell membranes, especially in the bloodstream. Also, we found out that if a drug activates the PDE5 more than normal, then it would inhibit erections. We'll get into that more later. Let's start with cell signaling, cell communications. So basically, permeable membranes where some molecules can pass and others cannot. There are permeable membranes where some molecules can pass and others cannot. Ligands are signals for receptors to make external information into internal information. So that's called signal transduction. So signal transduction is when a ligand, which could be a hormone, remember, hormone is hydrophobic, or an environmental stimulus, which could also be hydrophilic, which we will find out that just takes longer to create an effect, as opposed to hormones, binds to a cell receptor on the plasma membrane and creates a cascade of messengers to activate a response. That's signal transduction. Now there's natural signal transduction, and then there's signal transduction caused by drugs. Natural transduction example is when epinephrine activates the fight or flight response, which breaks down glycogen into glucose for muscle metabolism. Then the drugs can act as ligands. So epinephrine was a ligand in the natural signal transduction. Now there's drugs that can act as ligands as well, such as isoproterenol, which slows down the heart rate and is a beta 1 and 2 adrenergic agonist, but it's a sympathomimetic since it mimics the fight or flight. So I believe I said that it slows down. I believe it increases heart rate, because if it's a sympathomimetic. So if it's gonna activate the fight or flight, then it's going to increase the heart rate. That's used, now this makes more sense. That's used for people who are bradycardic, or if they have an adverse reaction to insulin's resistance. So yes, it makes more sense now. So isoproterenol will increase the heart rate of a bradycardic patient. Okay, now we're going to go into what's an agonist and antagonist and mimetics. An agonist basically activates receptors or enzymes. An antagonist inactivates receptors and enzymes, such as the drug propranolol, which slows down the heart rate. So that sounds like it would be a parasympathomimetic. Anyways, and then mimetics mimic natural signals. So agonist activates, antagonist inactivates. And an example of an antagonist would be propranolol An example of an agonist would be isoproterenol. Now let's get into enzymes. So enzymes are proteins that catalyze reactions and usually are done by hydrophobic drugs, like sex hormones. They require lower active energy, which make the reaction quicker. And so that is what catalyzing means. Um, they can form new molecules and products after the substrate binds to the active site. There is also competitive inhibition, which is generally an antagonist, and it can be irreversible if it's a very high potency drug, but usually they're reversible. That's competitive inhibition. Then there's non-competitive inhibition, which there's not much information on that. But at the end of the day, we want to understand that drugs like sildenafil is a PDE5 inhibitor. It inhibits an inhibitor to cause an erection after sexual stimulation. And so that kind of goes back to what we were saying in the beginning. If a drug activates PDE5 more than normal, it would inhibit erections. So we don't want to activate PDE5. We want to inhibit PDE5. So you inhibit PDE5, then you would get an erection. Hence why sildenafil is a PDE5 inhibitor. It inhibits an inhibitor. Great. That sounds perfectly clear to me. Let's go into lecture 2.2 now, which are routes of administrations. This should be fairly easy. These were the answers to the lecture quiz after the video. We'll start with that. So intramuscular is when the long needle goes in at 90 degrees. Intravenous is when an injection goes into the vein. Subcutaneous is when a short needle goes in at 45 degrees. So intramuscular long 90 degrees, subcutaneous short needle 45 degrees. A soft gel or a gel caps is liquid surrounded by solid gelatin. A capsule is solid pellets or powder surrounded by a shell that can be taken apart. Cough drops are lozenges. Syrups are liquid with dissolved drugs. And insufflation means snorting it. So there are oral solids. Now let's get into what the routes, the ways we can take these routes. So oral solids are tablets, meltlets, soft gels, gel caps, capsules, caplets, and effervescent tablets. Oral liquids are syrups, suspensions, and lozenges. Then topicals are epicutaneous, not to be confused with subcutaneous, because topicals are placed on top of the skin. So like ointments, gels, eye drops, inhalation and insufflation would also be a topical type of drug. Inhalation through the mouth, insufflation through the nose, sublingual, subgingival, and transdermal. Those are all topicals or epicutaneous. And then there are parenteral routes, which are IV, intravenous, intramuscular, subcutaneous, and intrathecal, which is through the spine and the spinal fluid. So subcutaneous falls under the parenteral routes because you're going inside, as far as epicutaneous, which is on top of, okay? And then there's also the rectal routes. Now, we're gonna get into the pharmacokinetics. This part is pretty thick. So let's start first with the Q&A quiz. So the first question for the Q&A quiz was, imagine you are dosing a drug that increases plasma concentration by 500 micrograms per deciliter every time it is administered to the patient. You dose it every hour via IV. The half-life of the drug is 1 hour. What will be the steady state concentration minimum and maximum? So the answer was 500 to 100. So steady state minimum plasma concentration is equal to the amount that the drug increases plasma concentration for each dose. So that's 500. So the maximum is twice that. All right. So the maximum would be 1,000. So you are dosing um, at 500 micrograms per deciliter, and the half-life of the drug is 1 hour. Okay. So then it would be 500, which was the minimum plasma concentration. And every time you dose it, right, it would increase. So 500 times 2, so another 500. That's so the maximum is 1,000. Hope that's clear. Next question was fluconazole inhibits cytochrome P2C9, which metabolizes ibuprofen to an inactive metabolite. What effect would taking fluconazole have on ibuprofen's effectiveness? Well, the answer for this was that it would increase plasma concentrations. Again, so fluconazole is an inhibitor to the cytochrome type of cytochrome P50, which metabolizes to an inactive form, inhibits. So then that means what effect would it have on ibuprofen? It would increase plasma concentration of ibuprofen. All right, so let's hope we get some more clarity on that as we move along. We have now the two branches of pharmacokinetics. We got pharmacodynamics and pharmacokinetics. Pharmacodynamics are the effect of the drug on the body and the mechanism of action. Pharmacokinetics is the movement of drugs through the body and how it is absorbed, distributed, metabolized, and excreted. So let's start with absorption first. So with absorption, we're going to need to know this graph that has an IV and an oral way of administering a drug. We know that an IV usually starts at peak concentration the moment it is administered. And the moment is administered, it starts at peak concentration and it goes down and starts eliminating. When you take an oral drug concentration, it starts at zero concentration, then it slowly increases up to when it reaches its peak, and then it slowly eliminates. So the IV is starts at a higher concentration and eliminates quicker. So what we want to know too is that T1 over 2 is a way of interpreting what half-life means. So T12 is half-life. IV drugs are eliminated faster and start at peak with no absorption. So there is no absorption with IV drugs. Oral drugs are absorbed. They have to be absorbed in order to get the high concentration in the plasma. And so they reach a peak slower. AUC equals area under the curve, and it's used to determine bioavailability. Okay, so here we go. AUCIV, so whenever something is given through an IV, you start at the highest concentration of plasma. So that means it's 100% bioavailable. Then you have AUC other route. We don't know what that route might be. Could be oral, could be rectal, whatever. In order to determine bioavailability, you would get the AUC other route, whichever route that is, divided by the AUC IV, which usually is 100. And then you would multiply that times 100, and then you would get your bioavailability percentage. So an example would be 50 millimeters squared divided by, which is the AUC of the route, divided by AUC IV, which is 100 millimeters squared, times 100. That's going to equal 50% bioavailability. So bioavailability involves the area under the curve, the area under the curve in IV, and whatever other route. So you're going to divide those uh, and multiply by 100 to get your bioavailability percentage. Usually you'll input first in the calculator the other route, then divided by the IV route times 100, and then you get your bioavailability percentage. Still with absorption, kind of related to steady state plasma concentrations. Here we're talking about half-life again, and the time it takes to have a max steady state to a minimum steady state. And so, for example, we're talking about IV absorption is a steady. If you're doing IV, the absorption is steady at 100 plasma concentration. It's a straight line. However, when you're taking oral drugs, that takes more time. So, as shown in the graph in this example, we show that the dosing is done at every 4 hours, since the half-life for this particular drug on this graph is the half-life is every 4 hours. So you take the drug, then the plasma concentration decreases after 4 hours. Then you would have to take another dose of the drug, and then that will increase it, and then it slowly goes out, increase, and then you want to reach a steady state, right? So in this example, a steady state was reached after 12 hours. So that is 1, 2, 3, 3 doses. So in this example, you have the 200 steady state max, or CSS max, and 100 CSS minimum, steady state minimum. Yeah, this was a little bit difficult to understand, but we're going to roll with the punches here. Then we're talking about distribution of drugs. Distribution of drugs, okay? So most drugs enter the bloodstream through the digestive system. Also epicutaneously through a topical, where they place it at the target site. Also, we want to know about distribution of drugs, that lipid-soluble and non-ionized drugs, such as diethyl ether, as a general anesthetic, can pass through the blood-brain barrier, the central nervous system, and the placenta. So lipid-soluble and non-ionized drugs makes sense, because we were just talking about how ionized drugs can't, right? So lipid-soluble, and I'm thinking that's hydrophobic, and non-ionized drugs such as diethyl ether, when they're used as a general anesthetic, does pass through the blood-brain barrier, the nervous system, and the placenta. Okay, still on distribution, you have distribution can exist in 2 forms. There's the free form and the bound to plasma form. The free form causes the therapeutic effect. The bound to plasma protein form, to albumin, cannot bind to a receptor with no effect on the body. Usually happens with older patients. All right, let's go into the metabolization of drugs, which is also the oxidation of drugs. So metabolization usually happens through the liver, through liver enzymes called cytochrome P450s, or CYP 450. Also means breaking, this metabolization also means breaking them down to other molecules which have been inactivated, which can also be activated, or they can stay the same, or they stay activated. So one thing that's very important, we need to know what prodrugs are. Prodrugs must be metabolized to be active. So when you take it, you're not going to feel it until the liver starts processing it and then it starts kicking in. An example of this will be codeine. Codeine is metabolized into morphine, which is a much stronger analgesic than codeine. But if you take codeine first, you're not going to feel it until it starts metabolizing through the liver, which then turns into morphine. An example of something else would be like Valium. Valium stays active throughout metabolization until it's excreted. And then other drugs go from active to inactive. Usually that's what most drugs are. So again, just know that prodrugs have to be metabolized in order to activate. Okay. So another thing we need to know, induction and inhibition. If it's metabolized by the liver and then the potency is decreased. That's induction. If it's activated by the liver, such as prodrugs, um, that then the potency increases. So again, if it's metabolized by the liver and the potency is decreased, that's induction. If it's metabolized by the liver and then it's activated, then the potency increases. And that's an example and that's in induction and inhibition. And an example of inhibition is going to be the prodrugs, such as codeine to morphine, since the potency increases after it is metabolized by the liver. Inhibition. Again, really quick, induction potency decreases. Usually that's the normal route with other drugs. But then prodrugs, once it's metabolized by the liver, the potency increases. So that's inhibition. So normally induction, but there are drugs such as prodrugs that do inhibition. And so just to kind of give you a better example here, if we have Valium, for example, and then someone also is taking omeprazole, well, that's going to inhibit the effects of Valium. However, if someone's taking Valium, but then they also take barbiturates, that's going to induce worse effects. So again, diazepam Valium is inhibited or deactivated by omeprazole or also grapefruit juice, but it's made worse by barbiturates. Also, you got to know that the hepatic portal vein connects the small intestine to the liver. And the way that drugs are excreted are usually through the kidneys, which is called the renal route or the urinary system. That's the most common. And it's usually filtered through nephrons and the glomerulus, which are the capillaries in the kidneys. Okay, let's get into this last lecture here, which is 3.1, efficacy and adverse reactions. The quiz Q&A. So vomiting caused by sleeping pill is a side effect, okay? And then also, if we want to find a therapeutic index for something, then we'll be provided the LD50 and the ED50. And so we want to input into the calculator first the LD50. So for example, LD50 is 500 milligrams and ED50 is 50. So then we'll divide 500 by 50, which equals 10. And 10 is a safe therapeutic index. Now, let's talk about potency, which is the amount of drug to produce an effect. The less a drug is needed to elicit the same intensity, the more potent it is. An example of this is between morphine and meperidine. Morphine requires a much lower dose for the same intensity as if you were to take a higher dose of meperidine. Okay, now efficacy is the maximal effect of a drug regardless of dose, so the maximum intensity, right? So as the dose increases, so does the effect. There's a dose effect curve, usually higher ceilings. So we're in the example of morphine and meperidine. Morphine has higher potency, which reaches the efficacy faster. or shall I say, reaches the efficacy with a lower dose. Um, Now, let's get into the adverse reactions. There's a couple adverse reactions. There's always a potential for adverse reactions, no matter the efficacy. So there's side effects, toxic reactions, allergic reactions, idiosyncratic reactions, teratogenicity, contraindications. So let's start with side effects. Really key here for side effects, such as what we said in the beginning of this part, which is vomiting when taking a sleeping pill. That is a side effect because it's acting on non target organs. Okay. Toxic reactions, they act on target organs. So, again, the side effects and toxic reactions are only similar in the fact that they are predictable and they are dose related. But side effects act on non target organs, which is why the sleeping pill causing vomiting is a side effect. And the toxic reaction, it acts on the target organ. Okay. Allergic reactions are not predictable and not dose related. So that's like type 1 anaphylaxis, right? So we can't predict that. We don't know the dose. It could just be little, it could be who knows what. Idiosyncratic reactions are just kind of like an unknown reason or an abnormal drug metabolism. So, for example, the Alaskan Inuit people, they metabolize isoniazid to an inactive form quicker compared to Caucasians. That's an example of idiosyncratic reactions. Then we have teratogenicity, which is when it's harmful to embryos and fetuses, such as drugs like tetracycline, metronidazole, and NSAIDs. Contraindications, that's pretty self-explanatory. So, for example, if a patient has stomach ulcers, then they should not take ibuprofen. Okay, so let's end it up with therapeutic index again. Therapeutic index means the safety of a drug. So the higher the number, the safer. Therapeutic index of at least 10 is considered to be a safe drug. Again, you divide LD by ED. So if the LD, here's another example, if the LD 50 is 400 and the ED 50 is 50, then you divide 400 by 50, which equals, no, no. If the LD50 is 400 and the ED50 is 100, then you're dividing 400 by 100. So the TI would be 4. 4 is not safe. Remember, we want at least 10 for a therapeutic index. Whew, this was a juicy one. Okay, so we should be learning how cell signaling works, how enzyme works, how drugs can affect cell signaling and enzymatic reactions. We need to compare and contrast agonists, antagonists, and mimetics. We need to know whether what a drug is likely to be membrane permeable or not, what types. We should also be learning how to compare and contrast competitive and non-competitive inhibition, which wasn't too clear on my part for the non-competitive. We should also know the various routes of administration. We should be able to define, compare, and contrast pharmacodynamics versus pharmacokinetics, which I think we did. We should also be able to identify drug absorption elimination graphs, such as the AUC, the peak, and the steady state, which we did. How to calculate a steady state range for an IV drug. I'm not too sure if we did, but I'm going to review that and make sure we hit that mark. Calculating bioavailability, we certainly did that. Explain barriers to drug distributions. Explain what prodrugs are and how the first pass effect plays a role. Going to review that too. Explain how the liver metabolizes drugs. We definitely did that. Explain how the liver inducer and inhibitors will affect drug plasma concentrations. Yes, we did go over that because that's the cytochrome P50 effect, which is the liver enzyme. So we talked about that. We also talked about how we're going to explain how renal elimination works. also listing routes of elimination, predicting the effects of urine pH on drug acidity and alkalinity. I don't think we talked about that. We definitely did not talk about contrast, zero order, and first elimination. Um, we did talk about potency and efficacy, and we did talk about TI, ED, potency, and the contrast between the different types of adverse reactions. However, now going back into the zero order and first elimination, that is something that I'm going to just review really quick before we end this video. Um, and the elimination part, right? So that's kind of like the excretion of drugs in the lecture, which talks about in the lecture 2.3 pharmacodynamics. Basically, that's the very last slide. um, and so, what we want to make sure we understand here is the zero order, first order elimination. So, zero order elimination are things like alcohol and aspirin. First order elimination are most drugs. Um, so, zero order has steady increments of elimination rate. So like 2.5, 2.5, 2.5, just steady by the same amount through time. The first order is like, for example, it is a 5 units, then 2.5, and so it's like half, 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 half. Starts five, then the two, then zero, 2.5, then 1.25. So doesn't eliminate at a steady rate, basically. So it could start by eliminating faster, then less faster, then less faster. It's kind of like a slope. Zero order is a straight linear slope, whereas first order is more like a parabola. It's funny how I bring that in. Maybe I'll remember better. Okay, so zero order, first order. Also, biliary excretion is when their drugs are excreted through poop. Okay, and drugs that are biliary excreted are drugs such as warfarin. Wow, that's interesting. Drugs that are excreted through the lungs are alcohol. Okay, so make sure you know that. Um, drugs, saliva, which is ultimately excreted through the feces, which is like phenytoin, which is our anticonvulsants. And then certain antibiotics, such as tetracycline, they can be excreted into gingival fluid. Okay. So, we want to just kind of touch up on alkaline and acidic filtrate. Um, Alkaline filtrate in urine is a weak acid and a weak base excreted. So the weak acid is excreted rapidly, but the weak base is excreted slowly. That's for alkaline filtrate. Alkaline meaning higher pH. Yes. So meaning if you have a weak acid, it'll excrete faster. Now you have a weak base, it'll go slower. Now if you have acidic filtration in the urine compared to plasma, if you have a weak base, which is a weak base, it's excreted more rapidly, and a weak acid is excreted more slowly. Wow, lots of information here. But that's it. All right. So let's remember all this stuff. Yeah? Okay. Um, the next video that I'm going to make will be the final one. And I believe it'll be an important one as well, because that's going to be all about non opioid analgesics and opioids, basically, um, and the mechanism of usage. Okay, thank you very much.